Namaskar, dear viewers. A very warm welcome to our session today. And today we have a very special guest, Dr. KR Ramanathan. So, sir is originally from India and now he's based in Singapore, working in Singapore. And he is a cardiac intensivist of eminence. He is the director of ICU Fellowship Program at National University of Singapore. And he's research director, Department of CTVS, National University, Singapore. He's also the associate professor, National University of Singapore, and he's chaired the publications committee, also, and also the past chair of scientific organizing committee, also USA. And very importantly, he's been cited amongst the top 2% of scientists across the world by Stanford rankings. So really, that is a very remarkable achievement, and we are really honored to have you with us, sir. You have spared your time to make this presentation. And the topic today is cardiac devices. And this is more for general intensivists because most of you are general intensivists. It's a general talk on cardiac devices. You know, these patients are coming to the ICUs, are general ICUs, surgical ICUs, medical ICUs, and sometimes you don't know what is happening, what to do. So I think sir will kind of throw light on all these devices. So we are better off at the end of the day. Over to you, sir.
Thank you very much, Tapesh, for that introduction. This was a lecture which was long time pending. So clearly delighted to be here. And I'll get down to business straight away so that we don't waste time and we can spend some time taking some questions at the end of the talk. How do I get to... Wait a second. Right. So, Tapesh, audio is clear, isn't it?
Absolutely, it's a great. You got a great connection there. Internet
No
is
worries. No worries. Thanks. Again, it's great to be talking to you all on a Sunday evening. And Tapesh has asked me to cover some cardiac devices, which is more from a general intensive care unit perspective, so that you are aware of it and at least know the basic components of how these devices work and when it should be used. Again, I don't want to make this too hi-fi, high-tech, because every other gadget that's used in ICU also gets used in cardiac ICU, and cardiac ICU uses special gadgets as well to sustain and salvage lives. So I'm just, I'd rather limit myself to a few devices. Clearly, if I can go on and on for hours together if the entire gambit of devices need to be covered. So at the outset, I'll just show you an X-ray of a typical cardiac patient that I get to see in my ICU on a day in, day out basis. This is a complex cardiac patient, usually post-cardiac surgery. Now, I'm just going to spin this as a question for you. It's a quiz. So I want you to identify all the plastics and metal devices or metals in this X-ray. Identify whatever you can and put it up on the chat. You'll get 30 seconds to look at it. Identify as many plastics and metals as possible. And then we will eventually check the answers at the end of the talk. I hope it's a good exercise to brush up, but I'm just portraying something which I get to see day in, day out. So these are the kind of patients who are sick, who come to us. They all need different kinds of monitoring devices, different kinds of other devices to support life, devices that are used therapeutically as well. So clearly, that's the complex nature of these patients. So, yep, another 20 seconds. Please have a look at this X-ray. See what all plastics and metals you can detect from this chest X-ray. Let's see who identifies the most. And I think that's a good exercise. Right. Another 5 seconds and I will move on to my actual talk. Right. If you're able to identify some of these, plastics and metals, I'm sure you have some basic intro into cardiac critical care. However, there are some devices which we tend to use exclusively in the cardiac intensive care unit. And very often, some of these patients need these devices outside the cardiac ICU as well. So, to list a few of them, we have the pacemaker, which is essentially used in certain circumstances. And clearly, I would think a general intensivist should know at least something about the components, the pacing mode, the indications for this particular device. You also have the intra-aortic balloon pump. Again, the general intensivist should know the practical aspects of how it works and some of the common troubleshooting exercises. I'm not talking about advanced. Some of the common troubleshooting exercises when you use a balloon pump in your ICU or in your patient. Then I'll just briefly, touch upon some of the MCS devices. These are advanced devices that are exclusively used in the cardiac intensive care unit. But then, I expect you to have a working knowledge at least about these devices so that when somebody starts talking about these devices, you identify them as to how they work. And last but not the least, I'd also share some interesting images that I have. And these are images probably exclusive to cardiac intensive care unit, but then, these are images that help you to identify a lot of things. Again, to keep this talk interesting till the end. So let me start with the first of the lot, the pacemaker. So pacing in cardiac intensive care unit is an important thing, and we use it for certain patients. Clearly, when I talk about pacing, I need to talk about what are the components of a pacemaker, how is the pacemaker coded, what are pacing modes, because these are some of the jargons that are used when you use a pacemaker in your unit. And we will talk about some of the other things like indications and other things. So, an artificial pacemaker. I mean, we all know that the heart has an intrinsic pacemaker, but the artificial pacemaker is an electronic device that delivers an electrical impulse to the heart, which facilitates contraction. So, essentially, if you look at the components of an artificial pacemaker, it will have a pulse generator. Then you will have the pacemaker leads, and of course the electrodes. And these leads, as and when or where they are connected, they would generate or they would transmit impulses from the pulse generator to the heart to stimulate the heart so that the heart contracts. Now, when we talk about the pacemaker, we also need to understand that pacemakers can be of different types based on how the pacing occurs. So, if you are looking into a post-cardiac surgical patient, you may find that these pacing wires or the pacemaker is used through epicardial pacing wires, and such types of pacemakers are called as epicardial pacemakers. You can insert these pacing wires into the heart through the veins. So, such patients would have a transvenous pacemaker. You can pace the heart even without any device at all by just placing pads on the chest of the patient. These pacemakers are called the transcutaneous pacemakers. And of course, a small cohort of patients would need pacing for a long term as part of maintaining their electrical rhythm in the heart. So such patients would need permanent pacemakers. Now, my talk is essentially going to be limited to the general principles of how the pacemakers work. And clearly, there are certain indications for which pacemakers are generally used in ICU. So when your patient, say, presents with sick sinus syndrome or different kinds of heart blocks, or with drug refractory dysrhythmias, it's very common to have temporary invasive cardiac pacing in them. Mind you, most of the patients who undergo cardiac surgery do get it on a routine basis. It's used more preemptively, prophylactically, so that when these patients come to the postoperative intensive care unit, and need either to increase their rate or increase their cardiac output, we use pacemakers at that point of time. Now, when we talk about pacemakers, there are a few things that needs to be clarified. Okay, as I said, the pacemaker jargon, or what we called as the dictionary of pacemakers, uses a different set of words, different set of medical, words that we need to know. So when you're talking about pacemaker, universally, we need to be talking the same language. Now, the pacemaker nomenclature essentially has been coded by different systems. So you have the NBG coding system that where pacemakers are classified based on their pacing capabilities and function. But we generally tend to use the alphanumeric code where we identify which chamber is paced, which chamber is sensed, and what is the response to sensing. Now, these are words I've already started using, but I'll clarify it in the next few slides. So for those who don't understand these words, just understand that we use the alphanumeric code, which is easier to understand and which classifies pacemakers based on how they pace the heart and where they pace the heart. So that's in general about the pacemaker nomenclature. Now, to dive deeper, we'll look into each of the words and what they mean. The word pace in the pacemaker dictionary means to deliver an electrical impulse. Now, the word sense in the dictionary essentially means it's the ability of the artificial pacemaker to detect an intrinsic electrical cardiac activity of the patient. So that is sensing. Now, apart from this, there are a few other jargons we use. You use a word called as pacing spike, which refers to the stimulus from the pacemaker, which is recorded on the ECG as a short, narrow deflection. I'll show it how it appears in the next few slides. Then we use the word capture, which essentially means the depolarization of the heart by the artificial stimulus. So clearly, the myocardial cells, they capture the impulse delivered by the pacemaker. And this is what you get to see as a pacemaker spike in the ECG. Now we again take another deeper dive to understand this nomenclature better. Now, I've used certain words which are commonly used in the pacemaker world. Now we need to name the pacemaker so that when you talk to somebody about the pacemaker, you try to define how this pacemaker works. So that is essentially made easy by the pacemaker nomenclature by which it is represented. So the pacemaker nomenclature uses a 3-letter sequence to identify what kind of pacemaker it is. Now, it's always not a 3-letter sequence. We have grown in technology to expand this to about 5 letters. But for all basic understanding purposes, the first 3 letters are extremely important. Now, the first letter of the pacemaker nomenclature refers to the chamber the pacemaker paces. So essentially, it can be an atrium, it can be the ventricle, or it can be both the atrium and the ventricles. And depending upon it, the first letter of a pacemaker would either be A, V, or D. The second letter refers to the chamber it senses. So wherever the myocardial potential happens, the pacemaker needs to sense that potential. And that is represented as the second letter. So again, it can be one of the 3, where it is A, V, D, or none, where it is O. The last letter is usually the response to the sensing. So based on whether there is an intrinsic rhythm or whether an intrinsic rhythm is sensed or not, the pacemaker then decides, okay, should I send the impulse or should I not send the impulse? Should I trigger an impulse or should I inhibit the impulse? And essentially that makes up the third letter of the nomenclature. So for someone who says I'm using a VVI mode of pacemaker, all it means is the pacemaker paces the ventricle, it senses the myocardial depolarization in the ventricle, and then decides if it detects a myocardial depolarization natively, its action would be to inhibit the impulse from the pacemaker. So that's in the broadest sense how the pacemaker nomenclature works. As I said earlier, the nomenclature has now expanded to involve programmable functions and anti-tachycardia functions. So don't be surprised if you get to see somebody saying, I use a VVIR pacemaker. All it means is this patient's pacemaker, in addition to being VVI, its rate can be modulated with the patient's intrinsic activity. So let's say he's taking exercise, the pacemaker can control the heart rate accordingly. And some of you might even get to see that, get to hear that a patient has a DDDRS or a similar nomenclature. All it means is that it has a shocking function for severe tachycardia in addition to the other four letters which I explained earlier. Now, let's go into some of the common pacing modes that we use in our patients. So your pacing modes essentially depends on, as we said, those three letters. So if it is going to be pacing one single chamber of the heart, these are single chamber pacemakers. So the single chamber pacemakers can be anything starting with A, O to whatever the second and third letters you can fill up the various permutation combinations. The common ones we use in clinical practice are the AAI and the VVI. Then we also use dual chamber pacers in ICU. So the common mode that we use is the DDD pacemaker. But less commonly used are the asynchronous mode or the AOO and the VOO mode. Now, to understand where certain pacemakers are used and where certain pacemakers are helpful, let me go through some of the details of each of these pacing modes. So first, about the AAI pacing mode. The AAI pacing mode essentially means that it paces the atrium and it senses the atrium. And if a native atrial activity is present, the response to that is inhibition. When there is no native atrial activity, it starts atrial pacing. So it's classically used in patients with sinus node dysfunction, but an intact AV node. So clearly, in such patients, it becomes useful. Now, if you look at VVI, quite similar, ventricular pacing, ventricular sensing. Similar to AAI, it's essentially the ventricles instead of the atrium. And these particular mode is essentially used in patients with chronic atrial impairment, say patients with atrial fibrillation or flutter tend to benefit from this pacing mode. The other pacing mode, again, which is again being increasingly used, is the DDD pacing or the dual chamber pacing. Here, atrial pacing occurs if there is no atrial activity. Now, the pacemaker then waits for the ventricle to respond. Now, if the ventricle has no depolarization by then, it goes into a ventricular pacing mode and starts pacing the ventricle as well. That's how it paces both the atrium and the ventricle after sensing for myocardial depolarization in the atrium and the ventricle. Last but not the least, in addition to these three modes, now there are other permutation combinations possible. I'm not going into the details of it. I just want you to know these terms, jargons, so that you're at least familiar with what these kind of pacemakers represent. Now, one more thing which I need to highlight is all these pacemakers can be modulated by using a magnet. So when you apply a magnet to a pacemaker, it goes into a asynchronous mode, irrespective of the initial pacing mode. So there is a magnet mode whereby you would use a magnet to convert any pacemaker into an asynchronous mode, which essentially means that such pacemakers which has a magnet attached to it, it delivers at a constant rate regardless of the native rate of the rhythm. Now, where do you use such modes? Well, you need to use magnet mode in certain circumstances, such as patients who undergo non-cardiac surgeries but have pacemakers. So clearly, when you have to take this patient to the OT, the anesthetist would then ask for these details of the pacing mode. And just to make sure that the diathermy used in surgery doesn't interfere with the pacing activity, he would use a magnet mode to convert it into an asynchronous pacing mode and thereby proceed with the surgery. Usually, this is a temporary use. At the end of surgery, the magnet is removed and the patient then goes back to his original pacing mode. So to give you a rough idea of where these kind of different pacing modes are used. Now, we spoke about the modes, we spoke about the various kinds of pacing. Now, there are other pacing jargons that you need to be aware of. Now, if you look at the pacemaker box that is in front of you, three things that will be glaring at you would be the rate. So, that is essentially the number of times the pulse generator would produce a pulse. That is essentially, in short, the way um, you decide your patient's cardiac output. So, the way the impulse or the number of times the pulse is triggered essentially decides the cardiac output, and you usually set the patient's a rate of anywhere between 70 to 90 in routine practice. The other two terminologies, again, these are again pacemaker jargons you need to be aware of, are what we call as sensitivity threshold and capture threshold. Now, sensitivity refers to the minimum myocardial voltage required to be detected as a P wave or an R wave. Now, it's measured in millivolts, and the lower the sensitivity, the more sensitive is the pacemaker. So, essentially, what it means is it increases the sensitivity of the pacemaker. Now, how do you set? So when you start using a pacemaker, you'll have to set the sensitivity threshold for that pacemaker. I'll go through that in detail. But the general range of sensitivity for a normal pacemaker is about 0.4 to 10 millivolt for the atria and 0.8 to 20 millivolt for the ventricle. The other jargon that we tend to use very often and that needs to be set is the capture threshold. So what does that mean? Now, you know that the pacemaker fires and the myocardium responds with a QRS following that pacing. So this is a successful capture, as we call it. So the minimum output where there is a capture is called as the capture threshold. Now, this is measured in milliamperes. So you need to understand how we set the capture threshold as well. For the sensitivity threshold to be set, as I said, it is the minimum voltage required to be detected when the pacemaker starts sensing for myocardial depolarization. So what you should do is you should set the pacemaker rate below the endogenous rate if present and place it in one of those modes. Then the sensitivity number is increased, which essentially means the pacemaker is less sensitive. So the higher the number, the pacemaker needs that much of an voltage to be detected before it senses. So clearly, you would make the pacemaker less sensitive till the sense indicator stops flashing. So there are two indicators on the pacemaker on the top. One is sense and the other is pace. So you increase this number till the sense indicator stops flashing. Pacing then should occur asynchronously after that. Once you reach that point, you then turn down the sensitivity. So that means the pacemaker is now becoming more sensitive till the sense indicator starts flashing again, which means it starts detecting the endogenous depolarization. So the number at which this occurs first is called as the pacing threshold. And usually when you set it on your pacemaker, you set it at half the pacing threshold. So this clearly allows for detection of small signals. And clearly, over a course of time, when these leads get fibrosed, it also allows for some leeway there. Now, the other thing which we need to set is the capture threshold. As I said, it's a minimum output that is required to stimulate an action potential in the myocardium. So if there is, you should not do it if there is no underlying rhythm. Make sure that there is an underlying rhythm and the patient can survive without the pacemaker. The pacemaker rate is set above the patient's endogenous rate, and the chamber of interest is consistently paced. The pacemaker energy output, that is the milliamperes, is slowly reduced till a QRS complex does not follow the pacing spike. So that is how you set the capture threshold. So usually the capture output or the capture threshold is left at twice the threshold. Again, this is to allow for a margin of safety. So these are some of the important things that you would end up doing when you have a pacemaker toy in your hands. Now, in addition to pacing this patients for bradyarrhythmias and similar dysrhythmias, the pacemaker can also be used to overcome some of the tachyarrhythmias. Not all tachyarrhythmias can be corrected. A few of the tachyarrhythmias respond to what is called as overdrive pacing. So what you do here is you pace the heart at a rate higher than the native heart rate. So let us say, your patient has an atrial flutter that's going at 140 or 150. You may want to pace their patient's atrium at a higher rate, say 220, to see if that can control the rhythm within the atrium to bring it back to normal. So rhythms that can be controlled with overdrive pacing are the junctional tachycardias, the reentrant SVTs, flutters, SVT with RVR. We usually don't try that with VT because it will precipitate VF. And AF, VF, and sinus tachycardia cannot be controlled with overdrive pacing. Again, another important use of the pacemaker in the general ICU. Now, when you have a pacemaker with your patient and you are operating it, clearly you're going to come across some of these scenarios which will need some basic idea of how you troubleshoot it. So your pacemaker may fail to pace. Your pacemaker may fail to detect cardiac signals, so fail to sense, and there can be some pseudo malfunction which needs some tweaking here and there. Now, I'm not going to go through all these troubleshooting techniques, but two things you need to know would be how to manage them under general principles and how to manage failure to pace, failure to capture. So what are the general principles of troubleshooting? Of course, when you have a pacemaker malfunction, the first thing you tend to do is review it with a 12-lead ECG. You then check the integrity of the circuit. So for that, you do a proper check from the patient end to the pacing end, making sure there is no break of circuit or there is no, twisting of the circuit whereby, these problems are caused. You make sure that the mode is clearly, switched on, and make sure that you have pressed the right rate on the pacemaker. You check for the capture threshold, and you may have to change the capture threshold after a few days the pacemaker is being used. So again, we just spoke about how the capture threshold can be readjusted. So you essentially might have to do it as part of your troubleshooting initially. You also check for sensitivity. Again, the same way as I told you earlier. Some of the times, if you just change the position of the patient, you may find that the pacemaker works perfectly well. Now, in addition to doing this, there are other fixes, such as, you may have to look at whether the equipment is worn off, whether the batteries need changing, whether there needs to be a reinsertion of epicardial wires or other wires. All these things will need to be evaluated. And while you are evaluating this, you may find that you may need a backup plan to meet some of the emergency situations. So what are the backup plan you do when you have a pacemaker troubling you? So essentially, I'll talk about it, but before that, let me cover how you deal with failure to pace. Now, failure to pace, essentially, you identify when your pacemaker spike should appear, but it doesn't. Okay, so there is no electrical output from the pacing wire tip. It's usually a lead malfunction or an unstable connection. Sometimes it can be due to, electrolyte disturbances. Clearly, you need to check the power. The usual bedside maneuver we all do is increase the output and see whether it works. We may even change it to an asynchronous mode to make sure that there are no other complicated things that is troubling this pacemaker. If nothing works, you prepare for transcutaneous pacing. Maybe in some instances, you may end up even preparing for CPR. Now, what is failure to capture? In failure to capture, you have a pacing spike. You have a visible pacing spike, but there is no electrical capture on the ECG. So there is no QRS complex or a P wave soon after the pacing spike. And it's again usually a mechanical problem. So, and very often you get to see this when pacemakers are used for a longer time because the wire myocardium interface gets fibrosed. So again, the approach to this is essentially look for all these mechanical causes, make sure that all the external connections are well tight. And again, if nothing works, you might need a transvenous or a transcutaneous pacing mode. Now, one other thing that can happen is the ability of the pacemaker not to sense. So here, the pacemaker fires anywhere in the cycle, and it produces, let's say, atrial or ventricular pacing when it's not appropriate. This can be dangerous. It can lead to RONT. So you'll have to do the same kind of general principles that we spoke about. Look for all these things as we did with the previous two troubleshooting. And as I said, you might have to prepare for other modes of pacing, maybe even prepare for CPR, sometimes even decrease the sensitivity so that it's easier to inhibit. So when we talk about other modes of pacing as troubleshooting techniques, I need to highlight how these other modes of techniques or other modes of pacing work. So there are transcutaneous pacing techniques, which is rapid, non-invasive, can be used by the bedside, and it's very handy in bedside scenarios or emergency scenarios. It has two pads that are applied to the chest, either anteriorly or anteroposteriorly, and you can use your usual Zoll machine that you use for defibrillation to transcutaneously pace as well. The transvenous pacing, however, requires putting in a central line, putting a pacing lead into the central line, and then stimulate the heart through the central line. So it's more invasive, but it's very reliable. Again, you have better capture. You can use it for a longer term, and your pacing thresholds can be very precisely adjusted. Having said that, it carries the risk of a intervention and clearly the complications ensuing that. The one other thing that we get to see in post-cardiac surgical patients is the epicardial pacing, more or less similar in principles, except that we get atrial wires directly rising from the heart being brought out of the chest along with the ventricular wires which are connected to the pacemaker box. The principles are more or less the same. And again, it's just that the kind of what do you say? The appearance is slightly different. Now, we do have newer pacemakers available where you don't need any wires, you don't need any leads. So clearly, you have detachable cardiac pacing leads where you can pace your heart with just a lead inside the heart, and your pacemaker lead or the pulse generator being elsewhere. So clearly, that's all. Those are the new kids in the block. Now, for patients who use pacemakers, be aware that there is something called as a pacemaker syndrome. It happens mainly because of, again, mechanical issues with the pacing system. There is loss of synchrony, and hence, there is dysynchronous pacing. The patient usually experiences symptoms because of ineffective pacing. So clearly, that causes a lot of anxiety to the patient as well as to the treating physicians. But it needs some presence of mind to detect that if your patient is on a pacemaker, there is this possibility, and hence this should be considered in patients with pacemakers. Management of pacemaker syndrome is more or less straightforward. You just have pharmacotherapy programming of the pacemaker properly, or you need to reprogram the pacemaker to make sure that things are altered. In refractory cases, when nothing works, you might have to do a surgical revision of lead positioning so that the pacemaker starts to work or function well again. So these are some of the aspects of the pacemaker that you should be aware of. I'm not going, as I said, into the depths of what the pacemaker functions or how the pacemaker functions, but these are superficial things which you need to be aware of when you are using a pacemaker. Next, we will talk about another device which is quite handy in patients who are in cardiogenic shock, the intra-aortic balloon pump. Now, it's classified as a temporary cardiac assist device. It usually helps the heart that is struggling in cardiogenic shock in two ways. It has a balloon. I'll talk about it in more detail. But essentially, it works by the principle of counterpulsation of a balloon in diastole. There is a balloon that inflates in diastole and deflates in systole, which helps coronary perfusion. These are some of the indications of Iabp that we regularly get to see in clinical practice. Very often in patients with myocardial infarction, patients who need high-risk PCI, cardiogenic shock from other entities. Again, clearly, as part of perioperative care in cardiac surgery, the Iabp is commonly used. it was first described in 1960. It works, as I said, using a balloon, and the balloon essentially gets inflated with helium gas. So one of those few instances where helium is used in medical practice. For postgraduates, it's a popular viva question or a short answer question where the uses of helium in medical practice gets asked, and this is one of those instances. Clearly, by way of evidence, there are few trials that have shown that IABP has not been shown to improve mortality. But having said that, whatever be the evidence that comes through with IABP, it still remains the most common temporary cardiac device that's used in cardiac practice. There are a few contraindications that where we do not insert IABP. So situations such as this would clearly, be contraindications to the use of IABP. Now, how do you insert an IABP and how do you exactly make it work? Usually, the balloon is inserted percutaneously, and femoral artery is the usual site where it's inserted through. It can be inserted through subclavian and axillary artery too. And clearly, surgeons can do it in many other ways when their patient is in the OT. But, the most common way of doing this is through the femoral artery. Now, these are the parts of a balloon pump. So, as I said, as and when you get access to the femoral artery, you insert a sterile plastic sheath inside it. Now, the IABP system has a console which is connected to the helium cylinder, which regulates flow of helium into the balloon. Now, the IABP sheath, which you get to see here on the left, you'll get to see that there are different parts of it. There is an extracorporeal tubing as well as a balloon membrane with gas and an inner lumen, which goes into the patient. So clearly, this particular sheath is introduced through this catheter. And if you look at the cross section of the balloon, this is how it looks. So the helium surrounds the blood lumen. So essentially, this has a transducer which you can transduce, and you can detect the patient's arterial trace. Now, the balloon can be sized depending upon the patient's height. So most of us would fall into the category of having height anywhere between 5 feet 4 inch to 6 inch, which makes such patients eligible for a 40 millimeter balloon, 40 ml balloon. And of course, the different balloons are available in the market. You need to be aware that you should not be using a longer balloon because you can block the superior mesenteric artery or the renal artery if you use longer balloons. So the height of the patient is very important when you size the balloon for your patient. The balloon essentially, how does it work? Clearly, when the aortic valve closes, the balloon distends. So when the aortic valve closes, it's diastole and the balloon distends. So essentially, when the balloon distends, it pushes blood into the coronaries, which then, augments diastolic coronary blood flow. So there is increased perfusion, there is increased oxygen supply to the myocardium, and this is actually what is referred to as augmentation. Now, during systole, when the aortic valve opens, the balloon deflates. Here also the IABP is helpful because it creates a potential space in the aorta whereby it sucks blood out of the left ventricle. So the ejection becomes easy. There is reduced resistance to LV ejection. So technically, the best way to say that is the systemic vascular resistance or the afterload is reduced. So clearly, aortic and diastolic and systolic pressure gets reduced. The important points to note about the placement of a balloon pump when you put it in, so that it's optimally used. The position of the balloon should be 1 to 2 centimeter distal to the origin of the subclavian artery. So it should be just below the level of the aortic knob. So if you are looking out for the IABP catheter, look for the second and third intercostal space, and you will get to see the silver kind of structure sitting there, which represents the tip of the balloon pump. So this IABPs are properly placed. Now, if you look at this particular balloon pump, it's so dramatic that the radiographer has captured this X-ray in this ECMO patient of mine when the balloon has inflated, that it clearly shows that the tip of the IABP cannula is in the arch of aorta. So clearly, this balloon has been pushed in too far and the balloon needs to be pushed out. So going on to say that such improper positionings can happen and you need to be detecting them on chest X-rays. Now, let's come to how the balloon works and how you interpret the balloon function. So the important part of the function of the balloon pump is detecting the waveforms. So the balloon is supposed to inflate during diastole. So that represents the dicrotic notch of your arterial trace, which is essentially the midpoint of the T wave. So clearly, if your balloon can be triggered either by the pressure wave tracing of the patient or by the ECG tracing, it can also be triggered by other means, but most of the time we use either of this to trigger the balloon to inflate and deflate. So the midpoint of T wave in the ECG triggers the balloon inflation and the peak of R wave triggers the balloon deflation. And what it essentially causes, as we said earlier, it causes a diastolic augmentation right from the dicrotic notch, and the balloon essentially goes on to deflate just before the aortic valve opens. So it decreases the aortic end diastolic pressure. And it's clearly, timed just prior to the next systole. So clearly, this is how a proper waveform looks like on an IABP, where there is an unassisted aortic end diastolic pressure, and you would find that post diastolic augmentation, the aortic end diastolic pressure is lower. So is the assisted systolic pressure. So clearly, if you have to understand this waveform, you'll have to understand it in the context of a normal arterial waveform versus augmented waveform side by side. However, when we augment, when we use IABP for augmentation, we generally, when the cardiogenic shock is severe, we tend to augment it beat by beat. Now, there are certain factors that affect diastolic augmentation. Clearly, the patient's hemodynamics make a big difference. So if your patient is tachycardic, the augmentation can be poor. Again, when you may have factors related to the machine that may affect the diastolic augmentation. So clearly, as we said, or as we saw in that X-ray earlier, where then there is a kink in the balloon catheter, or when there is low helium concentration, it affects the diastolic augmentation. And of course, the very fact that you don't time or position the balloon pump properly also impacts on diastolic augmentation. Now, what are the important troubles that the IABP machine usually tends to have or tends to alarm for? Now, one of the things that you may come across is an early inflation of the balloon. So it happens before the dicrotic notch. Clearly, the physiological effects would essentially be that there is a premature closure of the aortic valve causing increased LV, EDP, or PCWP. So again, this is not good for the heart because the very idea of putting in a balloon pump was to reduce it. So it increases your oxygen demand. So this is something which you need to detect early and make corrective measures. You can also have a late inflation if you don't time it properly. Again, late inflation happens after the dicrotic notch. So there is suboptimal diastolic augmentation. So the very purpose for which the balloon is used is not being fulfilled. So you need to be aware that it causes suboptimal coronary perfusion. You can have early deflation during the diastolic phase. So clearly, you will have not only have suboptimal diastolic augmentation, the assisted systolic pressure may also go up again, leading on to suboptimal coronary perfusion and increased myocardial oxygen demand. Late deflation can also happen, which essentially means it happens later from the aortic valve opening. So clearly, there is no afterload reduction. Again, increase in myocardial oxygen demand and increase in the afterload. Again, need to be aware of these waveforms to detect IABP malfunction. So clearly, there are different troubleshooting exercises that we usually undertake by the bedside. You need to make sure that, such things don't happen. I agree that this might be a bit advanced in terms of when we do a lot of things, but at least simple things like losing the trigger or looking at the augmentation, looking out for helium levels in your cylinder, for battery and the leak in the Iabp circuit are common things which anybody can detect by the bedside and immediately troubleshoot. And last but not the least, I have to say that it still has only a class 3B recommendation with most of these societies. I still believe Iabp is here to stay because it's the most common MCS device used in cardiogenic shock. And clearly, the only place where the evidence is strong is in patients with mitral insufficiency and those with ventricular septal defects. So clearly, when we wrote the consensus statement for the Asia Pacific Society of Cardiology, we said that, the Iabp being least expensive would still have a place in the armamentarium of gadgets that you use in cardiogenic shock. Now, if you look at other cardiac devices that are used in ICU, you'd get to see things like ECMO, which is essentially a kind of an artificial heart lung. The ECMO is essentially a machine that can generate flows anywhere between 3 to 7 liters. So it supports circulation as well as it supports damaged lungs. The other device that is very popular nowadays is the Impella, which essentially is a percutaneously inserted left ventricular assist device. Again, I'm not going to the details of it. Be aware that there is a device such as Impella, which can be inserted into the LV in a failing LV scenario, and this device helps to augment LV function till LV recovers. You also have devices to support the right side of the heart. So you have Impella that can be used on the right side of the heart. You can use ECMO as to VA ECMO to offset the right ventricular preload. And there are other extracorporeal devices that can be used in right ventricular failure as well. Now, let's go and see some of these X-rays which are exclusive to some of the cardiac units. And I start off with X-rays on ECMO. So essentially, if you look closely, I'm not sure how far this is visible. There is a tubing out there that goes into the atrium. Clearly, it is a cannula that takes blood out of the heart. This patient has a veno-arterial ECMO, so his other cannula is in the artery. Now, this is an example on the right. You have the example of a patient who has a dual lumen cannula, which is essentially used mainly in pulmonary failure. So the dual lumen cannula sits very much in the right atrium, and it's a single cannula, so it facilitates extubation of patients on ECMO. Now, just a second. Yeah. The next set of devices that you need to be familiar. Again, I'm not going to the details, but I think, these X-rays make cardiac critical care very fascinating. It keeps you on your toes. Are these X-rays which are used in patients with left ventricular failure. Now, this is a device. This is the Impella device. The blue arrow again represents the part of the device that's outside the aortic valve. The orange represents the aortic valve, and this is the tip of the device, which is inside the left ventricle. So you can see this tip here. The green arrow it shows the tip of the Impella about 4 to 5 centimeters inside the aortic valve, and it's a MCS device used in cardiogenic shock. Another interesting X-ray where you have a left-sided Impella as well as a right-sided Impella. So if you look at it closely, this is the left-sided Impella that goes into the left ventricle. So Impella in the LV. There is an ECMO venous cannula. Sorry, this is not a right-sided Impella. This is an ECMO venous cannula. So essentially, this patient has ECPella. So he has an ECMO with an Impella. Again, these are severely sick patients who would otherwise die without these mechanical cardiac support devices. You also should know about some of these other devices such as LVADs, and this is how their X-ray looks like. The one on the right shows an LVAD device with an outflow and an inflow, as well as an ICD generator, an AICD in this patient. So again, these are complex patients who have been salvaged from the point of death. Again, these are right-sided devices, mainly the Impella RP. You can see how it nicely turns into the PA on the left. And the one on the rightmost X-ray shows patient who has both a left-sided impella as well as a right-sided impella, what we call as bipella. So again, these MCS devices are all used in patients in cardiac critical care. Now I come to the question I asked you before. Let's see how much you have identified. I've not gone through the answers that you have written in the chat box, but I'd like to bring up some of these plastics and metals that you probably would have noticed. So the easiest one would be the endotracheal tube, the central line. This patient has got a PA catheter. He's got an aortic valve. I can see some sternal wires. I can also see some transcutaneous leads. I can see some ECG leads here. So all these are plastic bits that are clearly used. Now, for those who have been very sharp, you might have detected the intra-aortic balloon pump. And clearly, for those who can see this, you can see the thin column of air just below that silver knob. So going on to say that the balloon was inflated. So if I have to make a guess and speculate about this patient, very likely this patient has had a stormy cardiac surgery for insertion of aortic valve. This patient has come back to the unit with a PA catheter, makes me think that this patient is in cardiogenic shock. He's had an unstable rhythm. And clearly, he's one of the sickest patient in the unit, most likely. I don't know anything about this patient, but I'm just making a story from the X-ray I get to see. And clearly, that's what makes cardiac critical care more fascinating. And to top it all, this X-ray captures the heart in diastole. So clearly, the Iabp being inflated, the X-ray has been timed so well that it has captured the heart in the diastolic phase of the cardiac cycle. So going on to say that this is what makes life interesting in cardiac critical care. Thank you very much for your patient listening. I'm more than happy to take your question. And thanks, Tapesh, for this opportunity to talk.
Yeah, Dr. Ramanathan sir, thank you so much. That was a wonderful lecture, great slides. As usual, you have a very good hand at making slides, lovely slides. A lot of artistry there and lovely X-rays, especially the last few ones, because most of the people have not really seen impeller devices and all on the X-rays. Yes, IBP definitely, but impeller devices are still not so common. So, sir, can you just close the window?
Yeah, sure.
So while we wait for any questions from the audience, I request the audience if they have any questions, maybe I can just put up a few points. So,
Oh,
sir,
yeah.
you mentioned something about spikes. No, everybody knows we get some spikes on the ECG when the pacemaker is pacing.
Huh.
Now we have also seen that sometimes there are no spikes.
Hmm.
So and sometimes the spikes only in certain leads, which I think is okay because depending on the orientation of the leads, probably there will be spikes only in certain leads. But correct me if I'm wrong. But sometimes there are no spikes at all. So what is the implication of that?
Yeah, so it depends, Tapesh, on how you interpret it. As you said, if this is a failure to pace, then you are dealing with a real pacemaker problem. So very often, when we don't get to see the spikes and the pacemaker box is functioning perfectly, you get to see the sensing light going off, but the pacing light not going off. It's a sign that the pacemaker is not pacing properly, and that is where we need to look at it differently and might have to do some immediate troubleshooting things. um I mean, as you rightly said, there can be situations where the pacing spikes may not be clearly seen in some of the leads. And one thing I would then suggest is to change the monitor leads and see if it is seen in other leads. But in such a scenario, I would definitely worry about a failure to pace, because that's more going to be a pacemaker emergency than anything else.
Yeah, thank you, sir. So then you also mentioned about overdrive pacing, which I think is a very interesting means of treating at least VT, which is the most worrisome. So where does overdrive pacing come in the hierarchy of treatment here?
That
For
is
VT.
something, very less often used in general ICU. And I feel that that's less often used because of the fear. Because we tend to use it quite often in cardiac ICUs. And that's probably because I have the cardiac surgeon standing nearby when I do this. But having said that, look, nothing to be afraid of. It's a known way of mitigating VT or atrial flutter. So I would think that if this patient, I mean, while you're trying everything from a pharmacological perspective, um, I would parallelly think about overdrive pacing if this patient has a pacemaker in situ. So usually in our circumstances, these things happen one after the other. So the patient gets magnesium, amiodarone, and the next important step that we then embark on is overdrive pacing. So that's the usual sequence that we do. And as I said earlier, few things. Um, you need to understand your pacemaker module well, because every pacemaker has a different way of activating that overdrive pacing. So you need to be aware of how you do it. You need to be aware of what overdrive pacing rate in your pacemaker is. So without understanding all this, when we try to do, things may go wrong. So if you have a patient with a pacemaker in situ and you are thinking about, or if you want to know the pacemaker in detail, I suggest during peacetime when there is no arrhythmias, learn how the overdrive pacing is set up for that pacemaker, so that you know it well. It should be a part and parcel of receiving any patient who has a pacemaker. You should know the entire details of not just the mode, not just the rate, not just the sensitivity threshold and capture threshold. You also should look into other nuances, such as how is the overdrive pacing set, what is the rate at which it's set, and then it gives you more confidence to use it appropriately, especially when you are resuscitating or when you are giving that first set of medications. I mean, we tend to use it very often. That's because we are used to it. But then, this is something which I would advocate otherwise too.
So you use the pharmacological means, and what about shocking?
Yeah, so clearly, unless and until there is hemodynamic instability, we don't cardiovert. So we do try, if the patient has a pulse and a decent map, we still try all these techniques before we cardiovert. So we don't directly go into shock, even in a cardiac unit. That the reasons for cardioversion or defibrillation is usually dictated by the hemodynamic stability.
In this overdrive pacing, the rate at which you said, supposing there's a tachycardia at ventricular tachycardia at 170, so you are supposed to set it at something like 10 more than that or 10% more than that. So there's some numbers, right?
Yeah, that's true. So it's about 10 to 15% more than that basal heart rate. So if it's usually pacemakers are set for overdrive pacing at 220. That's the usual rate that you get to see. But again, people would have tweaked it. They would have changed it. So whenever you get a patient on a pacemaker, make sure what the set rate of overdrive pacing in that particular pacemaker is. But as you rightly said, yeah, it's usually in the range of 200 to 250.
So then just a couple of questions for everybody, sir. We have these patients coming with all kind of devices now. There's pacing and there's CRT and there is defibrillator, and also should we be making out what kind of a device the patient has, and if we have to, then how should we make out?
Mm.
Sometimes the patient does not know actually the family is not there and stuff like that. So is it important really? And what kind of a concern should be there for the intensivist?
Yeah, this is very important because, what is happening now is most of these cardiac patients are now spilling over to general ICU for other pathologies. So clearly, you may have a patient who needs a permanent pacemaker device, but having an elective hernia operation and coming to you postoperatively. Or you might have that patient with heart failure who's had a CRTD device and coming to you for something else, say with acute V's or something like that. So it's important. it's important that you know about the device. So as part of history taking, make sure what device you are dealing with. So there is a big difference between saying this patient is on a pacemaker versus this patient is on AICD. So you need to understand what terminologies you're going to use, because these are all terminologies of devices, and you need to have that in your head as to what exactly the device does. So I think this is very important. It's a pertinent point you brought up, because these days you're getting patients with all sorts of devices coming to you. So you should be aware of, at least you should have a working knowledge of what the device is being used and what the device does also. So don't get too into confusion about how the device works. It's very important. And now, once you know that this patient has a particular device, it should be clearly, you will have to involve a multidisciplinary team when you handle such patients, especially those with cardiac devices. It usually goes hand in hand with consultation with a cardiologist on some of these aspects. Not, I mean, again, even then, even with the cardiologist, some of these devices are eventually handled by the technician, say from that particular company who knows how to handle it. But then decisions need to be taken if the device is malfunctioning. And that's where, knowledge, education about that device is very important, paramount, followed by, simple tasks at troubleshooting. So the general principles I outlined, it will hold good. And eventually, when you are dealing with a bigger problem, you will need a multidisciplinary team to work out what has gone wrong.
Thank you, sir. So I think at least a cardiology consultation once should be done for these patients, to have a look at
Yes.
the device. That would
Yes.
be the least. Okay, sir. Dr. Ramanathan, sir, thank you very much. Namaskar. And I really appreciate your time and the wonderful teaching that you have done on our forum. And I thank the wonderful audience that we had for their patient hearing. Thank you so much, sir. Thanks the audience. Thank you, everybody.
Great. It was a pleasure being here, Tapesh. Thank you very much.